So hello, welcome today to this Friday edition of the clinical cases we like to showcase every week. And this is a very special video today because I'm going to show you a very efficient way of managing those really difficult cases. So we're talking about cases where there are severe bends or highly calcified, or they're just the types of cases that you look on the x-ray and you think, oh my lord, I really do not want to attempt this type of case. So to put a little bit of context into this clinical case today and its protocol, what I would say is if you get your specialist endodontists or you got your special interest endodontists who do the cases day in day out, they are not particularly using any type of standard protocol. They're using a hybrid system. So you speak to any endodontist, you ask them what their system is, and they're going to be using a mix of different types of files. So you get your Wave 1 Golds, you get your high flex files, and then obviously the manufacturers sort of suggest a kind of specific sort of protocol that you're going to use these files. In this case today, we're going to use a hybrid system of two types of files. We're going to use the mini cut types of files, and we're going to use the tooth saver files. So just to give a little bit of background on the different types of files, the mini cut files I've been using for a while now, and one thing I would say about these files is they cut very efficiently, and for someone who likes to get down the apex, get the glide path file cutting really nicely, these types of files are absolutely fantastic. They do run at a higher RPM than most rotary files, but don't let that sort of put you off. Okay, these files are really nice to work with. And secondly, the tooth saver files, again, they are very well adept at cutting, but one really sort of novel aspect of these files is they can be used both in reciprocation and rotary. So Daniel over at Tooth Saver has patented a specific type of reciprocation movement where we're going to be using today in this specific protocol. Okay, so first things first, we're going to have a little look at this case. So this case is of an upper right 6, and straight away we can see that this tooth has a very poor prognosis. Okay, it looks like maybe there's a little bit of bone loss around the mesial root there, but that is a tooth that's been removed recently. But we have got significant bone loss around this tooth. Luckily, we've got sort of furcal bone there, but this tooth is in a very sore state. Okay, and obviously with our consultation process, these types of cases come in all day, every day. We speak to the patient, we tell them the situation, and then they obviously make their own decisions on if they want to go ahead with this treatment. And in this particular case, this patient decided to go ahead. And when we look at this case, we can see that, again, it's got a lot of bone loss, and there's no obvious canal space within the root canal itself. So to me, again, this could be highly sclerosed or calcified, or it could be open up. It's hard to say, okay? So the first thing we're going to do is we're going to completely remove the temporary filling material. I didn't place this temporary, so what I want to do is I just want to remove the whole thing, make sure the tooth is obviously restorable. Obviously what you don't want to do is just make a little hole in the top of the tooth, leave the rest of the temporary filling material, do the root canal, and find out at the end that the tooth isn't restorable. So we're just going to remove everything there, get rid of all the decay, and just make sure the tooth is genuinely savable. And obviously when we remove the temporary filling material, we can see that it is savable. And obviously we're all rubber dammed up. We don't do root canal without rubber dam, and then we're going to just irrigate. And I always think sometimes when you open up these types of teeth and they're just all sorts of muck and things like that in there, you use hypochlorite or your bleach for long enough, and it really cleans out this canal space. And the first canal we're going to go for is we're going to go for the palatal. As people know, I like to go for the palatal straight away. It's big, it's a nice easy thing to do, and then we're going to use this mini cut blackjack to open up the coronal third, and it transpires that the mini cut didn't do a lot of work here because the palatal is quite open. But we're going to be using the mini cut blackjack for the other canal, so we might as well just get it open and then give it a clean out. And there you can see here that I'm using this integrated apex locator. So after the blackjack, the first file we're going to use is we're going to use this 1503 mini cut, and we're connected up to the apex locator, and we're going to use this mini cut very, very, very gently down to length. And our integrated apex locator is showing that we're getting quite close to the working length. So we're going to use this D-finder here, and this is a size 10, 25 length. We're going to pop it in the palatal, and then we're going to hook it up to our apex locator, and we're just going to use nice, easy watch winding movements. So I have a Wilex apex locator as well as the one we're using on the motor, and you know, this goes to length really, really, really easy. We're going to adjust the rubber stopper, we're going to pop it out, and now we know that the palatal is at 21.5 millimeters. That's the working length. So once we're at the working length, we're going to use this 1503 again. We're going to set it to 21.5. That's the 0 reading on the apex locator, and we're going to shape the palatal canal to 0 with this 1503, and that goes really, really nicely, easy to length. Just super simple, really, really gentle. And you can see the integrated apex locator, as we're reaching the 0 reading, it's slowing down. I personally like motor to go to a slow and then a reverse out. I don't like the stop. Sometimes when it stops, it kind of gets stuck in the canal. So we've shaped the palatal, and we're going to just do a little bit of an irrigant. And what I'm going to do here now is I am going to skip a step. You can see on the flow chart here that after the 1503 you want to go for the 2003, but in this case what I'm going to do is I'm going to go straight for the 2503, because I know that this palatal canal is very, very, very wide, and so this is the mini cut 2503, and I'm going to set this to 21 millimeters, so that's 0.5 millimeters away from the working length. And again, I'm using the integrated apex locator, and as we reach the end, it kind of slows down, and you know, it's using these integrated apex locators are really, really good. You know, you kind of know you're at the working length. So we've shaped the palatal. So now what I'm going to go for is the MB canal, and we're going to go straight back to that blackjack, the mini cut blackjack, and we're going to use this to open up the coronal third in this MB canal. Okay, and again, the cutting efficiency on these mini cut files are absolutely astronomical. You know, it just saves so much space. I think the problem with these is you don't want to go too far with these, so you don't want to cut them too far because you might cause a ledge. Okay, we're going to use the 1503 again. Okay, we're going to have the motor connected up to the apex locator, and then we are just going to watch this glide path file just cut its own path. We're not going to push it down. We're just going to make sure this glide path file is just making its own way to the apex. And the cutting efficiency is insane. You know, and you can see here that the integrated apex locator is starting to slow down. So what I'm going to do is I'm just going to sort of adjust the stopper as it's going along. I've got skills just to sort of set the kind of suggested kind of working length with this MB canal, and we know now that it's just sort of reaching the 0 reading as it sort of stops and it sort of reverses back out, as you can see there. So just going to do a bit of irrigant, and I'm going to just sort of work out the working length here, and on the apex locator it's saying about 18, but the problem sometimes what you'll find is, especially if you're looking under high magnification here, you can see that the stopper is suggesting that the working length is 18 and maybe a quarter. Okay, now we haven't got rulers that are that accurate, and what I would say is, if I draw a line here, I would say that if the file is reaching this point, it's probably 17.5. I know that sounds a bit mad because this line here is showing 17.5, but actually I feel like 18 is at this point here. So what I'm going to do is I'm going to sort of suggest that this is kind of 18.5, maybe 18. Okay, so when I'm doing my working length check, I'm going to sort of keep that in mind, that it's just over 18. So just to check the working length, I don't want to just rely on my big sausage fingers with these massive rotary files. I'm going to check it manually with some hand files. So I'm going to check it with the size 10 D finder. I'm going to put the rubber stopper at a recognised point. And again, when we pop it back out, this now shows that it's at this line here, which is 80 millimeters. And if you notice, I've actually reached the 0 point with the 1503 mini cut file. So what I'm going to do now is I'm going to jump straight into the 2003 mini cut file, and I'm going to put this up to the 80 millimeter mark, and then obviously I'm going to shape this MB. And again, just watch the cutting efficiency with this file. It's just absolutely gorgeous. It's like a knife through butter. And again, just super gentle movements. Don't push the file down too much, and then back in with the 2503, and then this is now the two canals shaped. And we're about 20-30 minutes in. This is super efficiency. This is what we like. First of all, we looked at this root canal and we thought, Christ, this is a really difficult root canal. But already, by using these files, using the specific protocol, we've cleaned and shaped 2 canals already. So it's at this point what we do is we turn our attention to the distobuccal root. And when I opened up this tooth, I noticed that distobuccal orifice was not obvious. Okay. And this is always a little bit annoying, and sometimes it's because there's not a lot of magnification there, and you get your sort of D finder and you kind of have a little feel around. It looks like maybe the referring dentist has tried to have a little look with that with I don't know, sort of his hand files or his rotary or even his ultrasonic, and because there's a little bit of trough there. And I sometimes think as well, if you can't find a canal orifice, a really good sort of first line of attack is to use a high energy ultrasonic. What you've got to be careful, of course, is this can cut dentine, believe it or not, and can cause a perforation. So again, it's in this case I can't quite find the orifice, and I'm going to have to bring out the big guns, okay, or shall we say the small guns. So I'm going to use a low energy ultrasonic tip. So first of all, I'm going to use this kind of torpedo shaped burn. This is diamond tip, this ultrasonic tip, so we're going to be really careful, don't perforate. And I'm just kind of having a little feel around for some kind of orifice. And sometimes when you get all this kind of like a dust and the canal orifice opens up, you can see like kind of a little bit of moisture, but in this case it was completely dry. We're going to go back in with the high energy ultrasonic, and then we're going to give it a bit of a dry up, and then we're going to use the ultrasonics. And then if you sort of blow this all away now, you can kind of see there is a glint there of maybe there's sort of moisture coming from somewhere. So if you give it a good old dry, you can see the moisture. I'm going to get my size 10K file just to have a little tiny little look, because there's a little glimmer of hope there with that little glint of moisture. And I'm just going to push my size 10D finder in there, and we've got that sort of characteristic where the file is sort of in the canal. So we know we're in. Okay, it's very calcified, and what I'm essentially going to do now is I'm just going to watch wind this file back into. What I was slightly worried about there is that I had perforated the tooth. So what I did is I just got the apex locator on there really quickly, just in case. And you've perforated tooth because you put your file in and you put the apex locator on, and it screams 0 straight away, or it's through. So, but in this case, we found the orifice, put the apex locator on, and it was kind of suggesting that it was quite high up on the kind of working length level of the apex locator, so we know we're in the canal, but we haven't perforated. We're going to use the blackjack orifice opener, the mini cut orifice opener, and this is going to open up this coronal third with 1503. And unlike the other 2 canals, this 1503, when we were using this, it just didn't feel like it was gliding nicely to length. It was sort of getting a little bit stuck, and I was sort of having a little feel here. maybe just to feel a little bit extra here for the video, but you know, you shouldn't sort of bounce the file like that. But it just wasn't getting that far. So we're going to use the 1403 a tooth saver file, but in this case I'm going to use it in a rotary action, and I'm going to see if this is going to reach any further to the apex, and again it just won't advance. Okay, so worst thing to do here is to push it any further, okay, because you're going to possibly cause a file fracture, or you're going to cause you know, a ledge. A ledge is obviously, you don't want a file fracture, but a ledge is equally worse, especially in these really calcified canals. So I'm just going to measure this 1403, and I'm going to just sort of check how far we've progressed, and we've progressed to about 17 millimeters. This is really important because sometimes you want to know how far you've got. And the next file in the flowchart is using this 1803 file. So I'm going to measure this again to 17 millimeters. And then I'm going to use this patented movement. We're going to use this sort of reciprocation here, where it's 400 clockwise, 50 counterclockwise. And with the file off, we're going to reach it to as far as it can get, and then we're going to turn it on, and then we're going to sweep it out, okay? And again, you're in no rush. This is a really difficult canal to do. You're just going to push it all the way in and sweep it out. And you'll notice that the rubber stopper is slowly advancing to the point where, you know, it wasn't before. And then we're going to get the 2003, and we're going to use the patented reciprocation movement. We're going to push it to as far as we can get. Again, you can see the rubber stop's a bit too far away, and we're going to press the button, and we're going to sweep out. And we're going to keep doing that. Remember, lots and lots of irrigation. And you can see the stopper now is just ever so slightly moving apically, which is what we want to see, okay? So we're going to push it to as far as we can get, turn it on, and then sweep it out. And you can see again, this file is now starting to advance. So remember, really important to irrigate lots. Make sure you irrigate, okay? This is going to lubricate and get rid of all the sort of detritus. And we're going to go back to the 1403. This time we're going to use rotary. Of course, you can use the reciprocation movement. And you can see now that this file starts to reach to the end, okay? This is starting to negotiate past that point, that 17 millimeter point with it didn't before, and again it's starting to reach down there now, and you know, nice little sweeps. The integrated the apex locator is sensing that the file is coming near to the end, and you can see there as it reverses out is to the end. So again, same again, I'm going to check the working length with the ham file. You know, this gives you a little bit more control over the working length, and when we check the working length here, it's at 19 millimeters. Okay, so look, you know, we had a DB canal which was completely closed up. We used a bit of ultrasonics, and we've used this hybrid system to get to the end, and it has worked. And again, it's just the same protocol as before. We're going to use the 1503, go back to that, to the 0 reading, and then we're going to use the 2003 mini cut, and then we're going to use the 2503 mini cut. And that essentially is all three canals completely shaped. And you look at the x-ray at the start, and it just looks like an absolute beast of a tooth. And you know, we've shaped it within, you know, a really efficient time. So the last thing we want to do is we want to check for the MB2, okay? Usually the MB2 is hiding under an dentine shelf. We're going to use some low-powered ultrasonic tips. So these are specialized endodontic tips, like the tips we used prior with the DB canal. And I'm just going to remove this kind of sort of dentine shelf. And again, be very careful you don't perforate the tooth. I can tell you that I've done this from experience when you're just looking too much for the MB2. And you know, once I remove this dentine shelf, I'm going to use like a high-powered ultrasonic tip with a bit of water just to remove all the sort of dust away from this case. And I am not convinced that there is an MB2. You know, some people might look at the X-ray and go, "Oh, this has definitely got an MB2," but I just could not find one. And you know, I'm using high-power magnification. We're using a microscope. I just couldn't see any orifice at all. There was a tiny kind of sort of slither or ribbon that sort of branched off the MB1, and that was sort of shaped out in the original shaping protocol. And I think essentially that was probably the sort of embryonic sort of MB2 there. And I suppose what's different with these obturation techniques with this particular protocol is that obviously there's no matched cones. So what we're going to use is these kind of generic 04 taper cones, and I know I shaped these canals to a 2503, but for some reason this time I didn't have any 2503 GP cones, but it doesn't matter, okay? If anything, it might be a bit better to use these 2003 cones, and I'm just going to use this gutter cutter just to shape the end so it is 25, because when we're going to fill this canal space with bioceramic, there's going to be lots of space for the GP to vent all of this sealer out the way, so you don't get that kind of sort of vapor lock you get when you're trying to fill the canal space with sealer and the sort of GP points sort of bobbing up and down. So you can see here we're going to use these 2003 GP points. When I fit this 2003 GP to length, we can see that it reaches past the working length. So when I sort of push this down to length, the GP point sort of gets to a point and then drops inwards. So I know that likely the palatal is not 25, so we're kind of apical gauging. So the best thing is just to pull it out and then just re-gauge the GP point with the cutter. So in this case, I think maybe the apical diameter of this palatal is 30 or even a 35, and you can see here that it fits nicely to the working length, and we get a nice little bit of tug back. So don't be scared to make sure you check how long your GP cones are when you fit them in, and make sure you get that sort of perfect apical gauge, because you're going to take this cone fit radiograph and it's going to look awful, okay, and you're going to get really annoyed with yourself. So always make sure you check if the working length of the GP cone is at obviously the working length. And then similar with the MB cone, again we've got these 2003 GP points. I'm going to cut them down to 25, and annoyingly the MB cone does not go to length, so this is really annoying. So this is a different type of issue. So the palatal was too wide, but the MB cone is too wide, so it won't go to length. So again, what you don't want to do is you don't want to just leave it like that, okay? You're just going to jump back in there and reshape with a 1503, okay? It can be annoying, and sometimes it's a bit difficult when you've got lots of GP points in there, but I felt like with the palatal it was kind of out the way. So once I have shaped this MB canal, again, this now fits lovely to the working length, so I know that is at the working length. So we measure it here, and perfect, we are at 18. So we're just going to refit the cone, and then we're just going to cut the excess off. And weirdly enough, the DB cone just goes straight to length, nice and easy. Obviously, the MB canal and the palatal canal during the shaping process was really, really easy, and the DB was difficult. And, you know, it's just ironic that the DB goes straight to length. It's all nice. And again, sometimes I just like to place the cones in, check the working length. So use my my tweezers at the stopper point, pull it out, and just check the working length. And I know that is at the correct length. And then we're just going to take the cone fit radiograph, and it looks, you know, really, really nice. All of the GP cones are at the estimated working length, and I'm quite happy with this. And all that's left to do now is to do our final irrigation protocol. So we're gonna clean with sodium hypochlorite, EDTA, and then we're gonna dry with paper points. And we're gonna not be too shy with placing bioceramic in these canals, because there's lots of venting space with these very, very narrow tapered GP points. So we're just gonna fill it nicely, push these GP points nicely to length, and then we're just going to burn off the excess, okay? And don't be shy when you're doing this. You know, get lots of sealer in there, within reason, of course. And obviously you're going to use your Mach 2 pluggers just to sort of condense the sort of GP, sort of mushroom it, so it sort of, it kind of seals off the coronal third. And, you just do the rest of the other and you just obturate the DB and the MB just the same way, and we look at the post-op, and it looks really, really, really nice. Okay, the inside of the tooth is infinitely complex, and I think with these hybrid systems, what's really, really important is that you're gonna have these teeth where all of the canals aren't going to have the same diameter, you know, especially in upper sixes. You're going to have this huge palatal canal, and then you're going to have these kind of sort of sclerosed, kind of tight canal spaces. So in this particular protocol, we've got all the bases covered. So we've got the palatal is covered in the sense that it's nice and wide. So we've got the bioceramic and the smaller tapered GP points. That's gonna sort of fill that space up, and that's that kind of hurdle that we've crossed. But also in the same tooth, we've got the DB, which is very closed up. So we're going to use obviously that patented protocol using the reciprocation motion, where we just push its length off and then press a button. I'm going to sweep it out. And again, you know, you look at this x-ray and it looks really nice, super nice. I suppose the only criticism here is that I couldn't see the MB2 canal. I'm always really suspicious if I can't find an MB2 canal. And you know, sometimes, you know, we take CBCTs of teeth and there's obviously that kind of, you know, suggestion that there is an MB2, mainly because of sort of the cross section of the tooth. But sometimes, you know, rightly or wrongly, you look for it and you can't find it. And obviously that's just the sort of luck of the draw, and that's what you've got to sort of mention to patients about the risks and things like that. So overall, super nice result. Listen, if you like the channel, please like and subscribe. And we've also got the membership program. You know, the membership program supports the channel. You get early access to videos, and also I will answer questions via a video short, and then I'll place it in the members area for everyone to have a little look at. So overall, we've got a really nice case. Super happy with it. These files are fantastic, and I hope you've enjoyed it, and I'll see you next week. Bye bye.